This mini lecture is on fibromyalgia. And fibromyalgia is a difficult topic to really discuss because there's so much controversy on different things with it. It's very similar to, there's like an overlap between chronic fatigue syndrome and fibromyalgia syndrome and even chronic pain syndrome. So they kind of meld together a little bit, but both of these have been really recognized with a lot of patients who have psychiatric illnesses, and at least two-thirds of these patients that do have chronic fatigue and one-third of patients with fibromyalgia do meet the criteria for anxiety and depression. The causes of fibromyalgia are really unknown, although there's some understanding that they could be related to, as I said, depression and anxiety, but also they think that there may be some type of a effect between some type of autoimmune disease or some type of infectious etiology, but they really can't determine, and it is a diagnosis of exclusion. Some of the risk factors that are involved in these patients are that they have had maybe some type of a physical trauma in the previous 6 months. So, did they have some type of a car accident? Did they have some type of abuse that was going on in their life? They maybe were Gulf War veterans. They came back from the military and now they have a lot of anxiety disorder, post traumatic stress disorder, that type of thing. Also, maybe some type of infection has gotten in there, causing some of the problems, as well as stress and even the female gender in itself. The female gender in itself has a tendency to have a significantly higher risk factor than the male sex does. And even if a relative has had fibromyalgia, they think that there's some type of a connection with that. So it really has been hypothesized that both syndromes may have some type of muscle energy metabolism issue, or even some inflammatory or even an immunopathological disease of the muscle. There's also some links that they've had between sleep disturbance as well as sexual abuse or domestic violence. But it is really important to note that none of these have really been consistently confirmed, and they've done a lot of randomized and controlled studies that have not proven any of this. They've done some extensive work to explore, some of the infectious etiologies, such as focusing on Epstein-Barr virus and retroviruses and even some of the herpes viruses, but they really have had not any type of connection with those types of issues. These women usually present in the age onset about 30 to 50 years old, most, as I said, mostly in the female population, and they have a presentation of post-exercise fatigue. They have multiple joint pains. They come in with headaches. They have impaired memory. They're not sleeping well. They get sore throats frequently. They have restless sleep. And they've also had some issues with swelling in the hands and the feet and morning stiffness. So there has been a thought process with that autoimmune. Is there something related to rheumatoid arthritis or some type of autoimmune issue like that? There are comorbid conditions, psychosocial, in about 30 to 60% of these that do have active disease. And this is something that's often misdiagnosed. I've had patients literally go to a rheumatologist, and the rheumatologist said, "Don't expect me to diagnose you with fibromyalgia because I don't believe in it, and I think it's a fake diagnosis, and I'm not going to even discuss it with you." And of course, then they come back to the primary care provider wanting more answers, and they're very upset and crying, and so it's really a stigmatism when these patients are diagnosed with fibromyalgia and even chronic fatigue. Some of the common differentials you see with them is, rheumatoid, as I said, the chronic fatigue, but rheumatoid arthritis, the lupus, as well as myalgia, polymyalgia rheumatica, some thyroid and parathyroid disorders, the depression. There's a whole host, as you can see, of differentials, even down to Lyme disease. So you have to find out if the patient has been anywhere where they could have been infected with Lyme by a tick, in northern Florida, in the upper states, New York, in those states where they're rampant with those. The CDC has some diagnostic criteria, but it's based on mainly the clinical evaluation and the persistent and the relapsing fatigue. So it's really very difficult to pinpoint a lot of things on these, and some patients just don't fit the criteria of every little thing. When we're thinking about doing our focused assessment on these patients, we need to really focus in on the history using old carts and CAM for the symptoms and what has been going on in their personal life. Have they had personal trauma? Have they had any sexual abuse? All those risk factors that we talked about. And then, have they maybe had a mono-like illness or some significant GI illness prior to the onset of these symptoms? So it's really important to go back and make sure you get a good, thorough history. They're going to appear very tired, and they may have cervical lymph nodes enlargement, and they could have shoddy and non-tender lymph nodes. But for a true diagnosis of fibromyalgia to be made, they must have widespread muscular pain that's been present for at least 3 months, and that is the key. They should have the pain present in 11 out of 18 trigger points, or we also can call them tender points, so 11 out of 18 of those. And by applying pressure to those points where your nail bed, the examiner's nail bed, turns white, that's when you've pressed deep enough that you are going to activate those trigger points. And it should be on 9 key locations bilaterally. The pain at these sites should really be significantly different than the control sites. So when we say control sites, we're thinking about the patient's thumbnail or their mid-forearm. You should not expect those areas to be tender like you would in the 9 other areas. They are, there are no imaging tests really, to do advanced imaging tests like a CAT scan or an MRI are not indicated because there really are not any significant physical findings that justify for you to order those type of tests. So what we're looking at, is not even ordering the viral Epstein-Barr or the Lyme disease or anything like that unless there's something that warrants you to do that by history or even by physical exam. So really what we're looking for is the muscle enzymes, the creatinine kinase, the atolase, looking at doing an ANA, although it's often not really helpful unless there's some type of autoimmune disorder such as lupus that you do suspect. There's a lot of false positive results that incorrectly label these patients as having lupus. So you have to be very careful when you're trying to label them. But doing the muscle enzymes, the thyroid, rheumatoid factors, those are really the only diagnostic tests that you can come up with. So how are we going to manage these? Well, it really is very controversial. And as I said, rheumatology, many of them don't want to get involved in it, but I don't want to say that about all of them because they do definitely get involved. But the goal of therapy is really to get that patient to have the best quality of life possible within the limitations of that chronic disability related to their pain. So the 2 therapies that have really been shown to be beneficial in terms of symptom relief as well as increased function are the cognitive behavioral therapy, the CBT, because what that does is it changes the beliefs and the behaviors that are barriers to recovery. And it also is a graded exercise. So also increasing bed rest should not be encouraged. That's the worst thing you can do is tell them to stay in bed. It just reinforces in their mind, their diagnosis. There's also been some medications that are FDA approved. So Lyrica or Cymbalta, even the SSNRs, such as Savella, have been known to do give the patient some type of relief, But the corticosteroids have shown some benefit, but there's some risks of adrenal suppression. So we try not to use those as much as, we'd like to. Some of the different ones, Ambien, Elavil, the Zolpidem, the amitriptyline, some other antidepressants, muscle relaxants, anticonvulsants, and pain control meds. And this is where you have to be careful with this patient population because it's very difficult. We can't feel someone else's pain. So we tell people you're not having pain when they think in their mind they are having pain. So where does that end? Your narcotics should really be your last resort. And these patients sometimes have addictive personalities, and these are things that they can get addicted to very easily. The narcotics as well as the anxiolytics, the Xanax, the Valiums, those type of medication. Long-term prognosis is better than short-term prognosis, but certain factors have really been known to predict a poor prognosis. So if they have more than 8 medically unexplained physical symptoms, or they have a history of dysthymia, or they have chronic fatigue that's lasted more than a year and a half, or they've had less than 16 years of formal education, that's another poor prognosis. And if they've got it at an age greater than 38 when at that initial onset, that puts them at a different level of prognosis. Tylenol, tramadol, some of those medications have been known to help the patients, but there's really no evidence that shows that they do give excellent relief or beneficial relief at all. So, when we think about some of these medications, we try to use some that are not addicting, do not have the potential for abuse. Some non-pharmacological patient treatment. I tell my patients if you have a pool, get in the pool and do a lot of exercises in the pool. It helps significantly to do that. Or I tell them to join a gym or something where they can do that. But ongoing low impact aerobic exercises for cardiovascular. So whether they're walking or they're swimming or they're biking or doing some type of water aerobics in combination with cognitive behavioral therapy and maybe even some hypnotherapy or biofeedback therapy. These have been shown to do a little bit, but they do help to increase their quality of life. They don't always take the symptom severity away, but it does help with their quality of life. So we need to give them a lot of reassurance. We need to give them, ways to help them sleep better, to make sure they do have some support systems and even some websites that they can go to, and then doing follow-up with them. And then consulting, it's usually not necessarily to do consults on these patients because they're probably going to be turned away unless you can find someone who really specializes in fibromyalgia that really understands these patients. Because if not, then you may need to do psychological counseling and evaluation. So they may need to have a psychiatric referral if you do feel that maybe their mood status warrants that. They could also see a sleep disorder specialist or even do some physical therapy. But this is really a disease where it's mainly about education, trying to get them to do something for themselves to feel better. They really need to understand that physical and emotional stress can worsen their symptoms. And so sometimes that's really hard for them to understand.